basically, in a short period of time, we're going to try and give you a brief overview of what's emerging as minimally invasive spine surgery. Okay, basically doing surgery through small access ports to do the same goals as we do in traditional spine surgery. So the goals basically is really to try and reduce the approach-related morbidity of the surgery that we're performing. In the meantime, still accomplishing the goals of traditional surgery. If you can't get those goals done, you shouldn't be doing it minimally invasively, okay? So just because you're trying, it becomes very difficult to do certain operations and accomplish certain goals minimally invasively, and you have to really figure out, can you do this minimally invasively or not? It really is a philosophy. There are some people who try and put their toe in the water and think they're a minimally invasive surgeon, and then they back out, and then they try it again, and that is just a setup for disaster. So you either accept the fact that you're going to do it minimally invasively, or you don't. And if you're really trying to be, I'm not sure, that just means you shouldn't do it. Because there's nothing wrong with doing things open, it's just that it's different. And if you don't feel comfortable, you really shouldn't go down that road. In our practice, we've been doing minimally invasive surgery for over 10 years. We've been doing minimally invasive fusions for about eight years plus. And now it's really patient-driven. Patients come in and say, I have this problem, I've seen this guy, that guy, and we know you do minimally invasive surgery. Can you do this? Can you do what I need through that approach? And so patients are driving this more and more. And I think it's going to force most people to eventually go that way. And the training routes have really just started to actually include that as part of the training. When I trained, it didn't even exist. Afterwards, it's now kind of mandated that people have to have someone in the training program to actually show people how to do this. So what are the immediate advantages? Smaller incisions lead to smaller scars. That's what everyone sees. That really has nothing to do with the actual underlying of the surgery. Less blood loss leads to less blood transfusions. And really the idea is less muscle and tissue trauma lead to less postoperative pain, less narcotics use, shorter hospital stays, and a quicker return to normal activities. And that's really what you're looking for. Of course, in the long term, you want to have the same results as the open surgery. Otherwise, it's really not appropriate to do it. So what are the long-term advantages? The less muscle trauma, it causes less muscle denervation, less atrophy. And there are actually even biomechanical studies and there are actually cellular studies looking at the muscles after open surgery. And there are definite changes that occur in the muscle from stripping the muscle off the bone. And that's what we think causes early muscle fatigue. Some people have had spine surgery, particularly fusions, will say, my back's always sore, I can't really lift like I used to. And the idea is that if you don't damage the muscle in the surgery, then maybe you'll have less of that after the surgery. So you want to, from a clinical point of view, minimize their functional limitations. Leaving the posterior elements intact, meaning leaving the interspinous ligaments intact, will help maintain lordosis of the spine, which allows you to maintain the balance of the spine. And again, theoretically, if you're in balance, you have a better chance of having a better outcome than if you're out of balance. And the big question that the spine surgeons always talk about is, can you prevent adjacent level degeneration by doing it minimally invasively? That has not been answered. It's certainly going to take a lot of data to do that. But when you do an open surgery and put screws in, the screws they get put at the upper level mean you have to expose the joint above, which is not the joint you're fusing. And when you do it minimally invasively, you don't even look at that joint. You don't do it, it just stays, it's virgin there. And the idea is that if you don't look at it and there's no way to really bugger it up, then you may not facilitate further degeneration. So we don't have an answer to that, but that's what everyone's looking at. So can we prevent further surgery? So what makes things possible? There's a lot of companies out there that have made very sleek, very sexy access systems that allow us to actually get to where we need to go. We didn't have this 10 years ago. The instruments have become modified, bayoneted long instruments where you can work in small holes. We didn't have that. And for instrumentation fusion, the companies have come up with very sleek, percutaneous ways to place hardware and do some pretty big constructs, even scoliosis surgery, minimally invasively now. And that's all really rapidly evolving in the last probably 5 years, really exploding. The operating microscope is key. It keeps improving, which is very good. And good old fluoroscopy, because without it, you really don't know where you are sometimes. So I'll show you a couple pictures of that. So what are the challenges? I'm going to touch on these each individually, but basically it's a limited anatomic orientation. It's easy to get lost. Small approach portals make it technically difficult to do the surgery. It's limited anatomic visualization, hard to see what you want to see unless you really know what you're looking at. And then the surgeons really don't have a lot of experience doing it. So here's a picture I took from a book, limited anatomic orientation. Here's a tube. Here's some black stuff, which is probably muscle, I don't know. There's some white stuff, and basically you're lost in the spine. You have no idea where you are. I don't. I looked at this and I said, that's a great picture for me because I really have no idea what they're doing. So for me, it's easy to get lost. When you get lost, you get nervous. The whole operation's done. Right at that point, you're done. So there's just no point in doing the operations if you're going to get lost. These approach portals, here's the size. This is a typical tube. When we do a lumbar discectomy, we use 16 millimeter diameter tubes, 18 millimeter diameter tubes. When we do fusions, we use 22 millimeter diameter tubes, okay? And I'll show you some of that. But that's a small working area. The bigger the patient, the longer the tube, the harder it is to do it. Sometimes the tubes have little bevels here to help us a little bit, but you can see that if you're not used to working in that small space, it can be very difficult and very disorienting. This is just a typical picture through a tube. This is the thecal sac here. Here's a nerve root. And the limited visualization is really one of the things that really distresses surgeons. I can see Dr. Vitale over there, and I can see Dr. Sethi over here, and I can look around, I'm happy. But when I do this, and I see Dr. Vitale, I have to believe that Dr. Sethi's there, and I can't be uncomfortable that I'm working on Dr. Vitale, but now I want to see Dr. Sethi. Surgeons don't like that. Even if they never look, they just want to go, I could look over there if I want to. It's a very difficult jump for people to make. And this is an example here. The spine heads up here. This is L4, L5, S1, and this is wanding. So I'm at the pedicle of 4, I'm at the pedicle of 5, I'm at the pedicle of 1, through the same incision, through the same tube. I can do what I need to do. It's just that I can't see S1 when I'm looking at L4. Some people just don't like that and they can't get over it. And that's a very difficult jump. And then it's limited for most spine surgeons, particularly people who haven't trained in the modern era. It's new, and the learning curve is steep, and it's very discomforting to the docs. And the learning curve is tough. This is a tube here again, thecal sac here, a nerve root here, a disc is here, and then you can see the space where the disc came out. But that's through an 18 millimeter tube. So when surgeons say, maybe we can't really see what you want to see, I say to them, yes, you can. You have to be willing to jump into it and believe that you can see it. So what are the applications? The three most common are really lumbar discectomy for disc herniation, lumbar laminectomy for stenosis, and then lumbar instrumentation fusion, which is for an unstable spine, okay? And that's usually in combination with the other ones. And I'm going to just show you 3 examples and to show you what we're doing. So the discectomy, basically, this is the same thing you do for all of them. You use a dilator to get through the muscle, then you put the working tube in, and you're going to work through the working tube. Okay, and so here's a Kwire going in to find our space. The dilator is going in right here, right there, and then the working tube. That's either a 16 or 18 millimeter working tube in this patient. And what you're looking at here, so the head is here, feet are here. This is through the tube. This is the thecal sac. The nerve root is hanging right behind my sucker. This is exposing the disc. Here's the thecal sac with the nerve root. Here's the disc. You can see the fragment now. I'm teasing it out, taking pictures for the camera. And then at the end, you see where the disc came out of the disc space here, thecal sac, nerve root, and then looking a little distally here, here's the nerve root, the yellow's fat. And so you can see everything you want to see through an incision that small. But you shouldn't do it if you don't feel comfortable doing it that way. It's okay to do it open. It's just, it is what it is. So for lumbar laminectomy for spinal stenosis, again, some people want to know what spinal stenosis. I always think of I-95, right? The nerves live I-95, then the shoulders, then the exit ramps. Spinal stenosis is you got 4 trucks on I-95 and the 8 lanes, so 4 lanes are closed. And this is a typical picture here. Here's I-95, now it's closed. And here's the same thing here. So when you look in cross-section, down here it's very, very tight. If you look at this white, it looks like Texas Longhorns if you're from Texas. Most people say it's Napoleon's hat upside down, right? You can see it. And so when you see that, that's very severe stenosis, okay? So that's what we're talking about when we're doing lumbar laminectomy for stenosis. Again, the procedure is the same. You get the working tube in. It's just a question, can you look across to the other side to free up the other side of I-95 from that single area? And here are a couple CAT scans showing the bony removal here and here that, in fact, you can certainly get across to the other side. So here's a patient who has a severe stenosis here. There's a central disc. There's a right-sided disc here. Again, here the canal is very tight. And we're going to just do a laminectomy with a discectomy on the right side. So looking through the tube, the head is here. The feet are here. This is the thecal sac here. Here's the nerve root right here. And then here you can see I'm retracting. That's where the disc was taken out. So we're on the right side of the patient. And now I'm done with that. I want to look across I-95 to the other side, and I want to see the other nerve on the other side. So in this picture, I'm looking across here. Here's the other side of the dura right here. So I'm across, so clearly the canal is decompressed. And if you see a hint, there's a little hint of a nerve right here. And now I'm just pushing the thecal sac down a little bit, and there's the nerve. So I'm able to decompress across both sides, take out the disc on the ipsilateral side, again, through the small incision. Now, if you have 5-level laminectomy, my partner Dr. Fury likes to do those, but they take a long time, and we've decided that after a couple levels it becomes more painful for the surgeon to do that. I mean, you can still do it, but so we kind of limit it to 1 and 2 levels for a laminectomy for stenosis. But the Holy Grail is, can you do instrumentation fusion through minimally invasive procedures? And the answer to that is yes. This is kind of just our experience at ONS looking. The yellow is really minimally invasive surgery taking off for 1 and 2 level fusion. So you can see in 06 it kind of exploded, and we've been pretty steady. There are some patients that just have certain things why we would choose not to do it. But the vast majority of patients who come in with regular stuff that need a fusion, 1 or 2 levels, can certainly have it done minimally invasively. So this is one case here where a patient had a history of chronic back pain. He's got a bad degenerative disc right here. He's had back pain for years. He was an ex-tennis pro. He's had a previous discectomy, and if you look closely here, here's bone, and you can see the bone has been removed here. So he had a previous discectomy, and now he's got a recurrent disc. So the idea of doing the fusion for him is to treat the degenerative disc with the back pain, because now he has another disc herniation. So we're going in to do the disc herniation again, so we might as well lock them together so he doesn't have to deal with it again. Actually, that was his point. We had to argue with the insurance company to get this approved, but he's doing fine. So here is just localizing. We localize in the AP and lateral way, and this is L5, S1, so head is up here and feet are down here. And basically, through our incisions, we're going to put a needle in. This is the pedicle here, the circle, when you're looking on the AP, and this is the column when you're looking on the lateral. And we put the K-wire in through the needle, then we remove the needle, and then we dilate up over here. So this is a dilator, soft tissue dilator, and you can see that we're tapping the hole. Then we just do it on the next level. Then we do it on the other side. So now we have the 4 K-wires in. So once you have the K-wires in, you're all set for your instrumentation for putting in the screws, because they just go over the K-wire. The screws are all cannulated. On the right side, because we're not operating on the right side now, we're putting in the screws percutaneously, the first screw, the second screw, and you can see that we put the rod in, and these things that are hanging out here are really screw extenders, because we have to have access to them outside the body. Otherwise, we can't manipulate or do what we need to do. So when you look here in the intraoperative picture, here are the screw extenders sticking out on the right side. There's the working tube right there, the operating microscope looking down into the tube. That's what it looks like at surgery. And when you look here now for this picture, the head is over here and the feet are down here. Thecal sac, L5 root, S1 root is being compressed by the disc herniation. And now here I'm looking at the thecal sac, the nerve root, and this stuff here that looks funny is really the scar tissue that we had to dissect away because he's had previous surgery. And when you do these, you have to really be able to prepare the disc space properly. If you can't do it, you shouldn't be doing it minimally invasively. And it's not like you go and say, oh, I see the disc space, clean it up, and then stick some bone in a cage, because if you don't do proper carpentry, you're not going to get a fusion, so it's going to fail. Just like it would open, if you don't do it right. So you have to go to the front of the disc space as much as you can. You can see the white here is air where we've taken out most of the disc here. I'm just showing you how far forward we are. This is now placing through the tube, placing a sizer just to know what size cage we're going to put in. And then when we're looking here, I'm actually showing you, here's the 5 root, the 1 root. This is the annulus in the front. This is the bone of L5, the bottom part of the inferior aspect of L5. S1's down here, showing that we're that far forward. And then you can see the cage has already been placed here. So when you look at it from an X-ray point of view, now we've put a bunch of bone up front before we started putting the cage in. And then we put the cage in, and you can see the black, that's all bone that we've put in. Okay, and I want you to notice here too, we've even been able to distract. See how that rod is a little short there? We did that purposely to open the space. But you'll see when you see the final pictures that we actually can compress on these too. So you can do a lot of stuff that you need to do now through these techniques. But here, this is an AP looking at what it looks like finally. Here's the ladder. You can see the rod's now sticking through the screw head. So we were able to distract to put it in, compress it to lock it together, again through pretty small incisions. And I put this in because I like it, but so this opens a whole new realm for me of tattoo-sparing spine fusion, because it's one of my favorite patients. She has this really nice son, and she needed a disc operation. If you look really closely right here, there's a little scar. I saved her son the first time. Then she got injured again, and she came in with this ugly picture. And she has a little slip here at 3-4, and she's got a foraminal disc out here, so she basically needed a 2-level fusion. But she wanted me to save her son, so I tried. So here's the incision planning, and here's postoperatively right around the edge here. And if you look, this is what we did. Of course, she wouldn't take the belly ring off for the X-ray, which was annoying. But and then I love this is great. And then here's the final picture, and blown up, and you can see if you really look closely, there's one of the scars, there's the other scar. And there's the old scar, but she's happy. And so I guess it's good. Thank you.